Pulm. These 32 slides we'll go over. Again, hopefully last test reassured you that most of the concepts you'll need to know, most of the keywords, most of the answers really. You can be pretty confident that these review slides will capture 99.999%, right? So at least all the topics. Maybe I would say go back if maybe a mechanism isn't clear or some sort of concept, but most of the things you need to know we'll do in the review. All right. Sorry, I had a lot of meetings today. We had senior OSCEs today. Those went really well. Everybody did great. Especially when we just keep using the same cases over and over again. After a while, everybody knows what JMC7 is. All right. So we talked about our pneumonia and stuff. What? Oh. No, it's how we number our cases. All right. So community-acquired pneumonias. So this is our first topic we talked about. Again, pneumonia is a lung disease. Literally translates into a disease of the lungs. So we're not in the airway, we're not in the pleura, we're in the parenchyma of the lungs where the oxygen is exchanged. The most common by far is going to be our community-acquired pneumonia. That means that someone developed symptoms, i.e. were exposed to a bug that caused pneumonia within the community. And those bugs are different in terms of catching them in other areas. Group settings, hospitals, dialysis centers, nursing homes, homeless shelters. So those bugs are very different. So saying community-acquired pneumonia means that we assume it is not one of our resistant, like our Pseudomonas or our MRSA. So remember, most commons, so strep pneumo. So patient has pneumonia, nothing else special about them. Most common bug, strep pneumo. Which is why we vaccinate for that. It is worldwide the most common cause of pneumonia. The viral pneumonias, again, they're going to be more diffuse patterns versus the lobar findings with bacterial. Then we've got our atypicals. So a little underline there, Mycoplasma pneumoniae. So the walking pneumonia. Someone is not 103 temp, Rigers, tachycardic, maybe hypoxic. So it doesn't really look deathly ill, like a bacterial pneumonia. Maybe doesn't even have a fever. Maybe he's like, I just kind of feel bad. Probably does have a cough. Big clue for you is going to be the setting. So it's very commonly going to be someone in basic training, someone in a dormitory, comes in. Maybe they have a small infiltrate on their chest x-ray, nothing crazy. They might be afebrile, just feel a little crappy. Most commonly, that's going to be our Mycoplasma pneumonia as the most common etiology of our atypical pneumonia. Again, very young and very old. Sometimes they have less obvious symptoms. So sometimes this needs to be in the differential for patients, even though they're not saying fever. Again, Carmel's mom was hospitalized for bilateral pneumonia. Never once did she have a fever. She has some mental status change, but I think that's just her baseline. All right, chest x-ray again. It'll tell you what the pattern is, but it won't tell you specific pattern. This is our curve 65. So important things to note about this are, what does C, R, B, and 65 stand for? So understanding what those mean, understanding if I give you a patient and I give you all their characteristics, I may ask you what is one characteristic about this patient that would make it more beneficial for this person to be hospitalized. So you're looking for that, because that's what that curve tells you about. It tells you disposition. It tells you recommended disposition. So knowing what these are, again, you've already determined they have pneumonia. Now you have to figure out, should I send this person home or should I hospitalize it? Because we already talked about that mortality rate and how high it was. So this is part of the treatment. Make sure the patient's stable and safe to go home. This is a tool that helps you make that decision. If they're 75 and they're confused and they're tachypnic and tachycardic and they're hypotensive, you're going to want to hospitalize them. If they're 25, otherwise healthy, sats are good, blood pressure's good, this is probably someone that you could disposition home. So knowing what those stand for, so that you can identify them in a patient description. Outpatient treatment. So if you're going to treat, so these three things, whether or not they've had antibiotics, their age, and any comorbidities or immunosuppression. So know what these are and understand that one of these three things would be an indication of whether or not you can use amoxicillin or macrolide or doxycycline versus if you have to consider augmentin. So I think it's important to understand these three things: their age, presence of comorbidities, immunosuppression, and whether or not they've had antibiotics in the past 90 days. So first you got to decide if they have pneumonia. Second, you got to decide if they need inpatient or outpatient. Third, you have to decide what to treat. That's outpatient. Inpatient, I won't ask you anything on that. That's something that you'll look up. Obviously, you're going to get the blood cultures or sputum cultures when you admit someone. Make sure you do that. Get the blood cultures and sputum cultures first. And then most cases you're going to consult to find out based off of, obviously this is community acquired, but you're most likely going to consult to figure out what's going on. If they're sick enough to be in the hospital, then usually you need to put them on a stronger medication. And then for outpatient follow-up, if you do end up dispositioning them, just consider bringing them back earlier versus later. If you let them go home, make sure you do earlier follow-up. You hospitalize them, obviously, that's your disposition. We've got the nosocomial, which cover our ventilator-associated, healthcare-associated. These are, like I said, healthcare settings, homeless shelters, dialysis centers, anything that where there is high level of disease. Organisms usually have greater resistance. These are our MRSAs and our Pseudomonases. We won't expect you to know any treatment on that, but understand that if their symptoms started 48 out within 40, so they got admitted to the hospital, and then 3 days later, right, greater than 48 hours later, they developed symptoms. So they by diagnosis, they caught that disease while they were already in a healthcare setting. So getting a history on patients is important. Have you been recently hospitalized? That's critical. Knowing if the patient goes to a dialysis center, knowing if they've been in a nursing home or if they work in a nursing home, because that'll tell us whether or not they have higher risk for exposure to Pseudomonas or MRSA, i.e. we need to consider coverage for those, but I won't ask you about that. Aspiration pneumonias, these are ones where usually we can aspirate all kinds of things, but this is one classically where you're aspirating gastric contents. This is a classic association to alcoholics. Very classic presentation is a homeless person who is an alcoholic, who was found down, who came in with very, 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 very high fever. Klebsiella, that's our very commonly associated. The most common pathology, the most common etiology for this is actually a polymicrobial, but Klebsiella, again, is a classic association. It's not the most common, but it's something that I've seen on PANS, so I'd like you to be able to make that association to aspiration pneumonia. It's that red, current, jelly-like sputum, which I've never seen, but I know it exists. Commonly seen in alcoholics. You need to make sure that you treat it very early, keeping in mind that you can use antibiotics for these patients, but if you image them and you see evidence of abscess, you need to put chest tubes in those patients. So very, very commonly, aspiration pneumonias develop into abscesses, which are obviously abscesses, or empyemas, which are associated with the chest wall. If you identify those on a chest x-ray, then you not only need to give them antibiotics, but you also need to drain it. And the antibiotic choice will be based off of sputum cultures or blood cultures. Empirically, it's going to be really a consult because these patients will be admitted. flu, we got flu A or B. It's seasonal, we know that. People come in with coughs, upper respiratory symptoms. It can develop into a pneumonia. So that is why it's very important that we treat this early on. Same thing with like you get a cold and then little kids will get the ear infections. So when things aren't moving and you've got inflammation, you've got a impaired immune system, bacteria loves to move in there and set up shop. So we want to make sure these people get better fast, so supportive care. When we talk about this thing called Tamiflu, Tamiflu is, like I said, very well advertised. There is studies that show that it decreases the duration of symptoms, but it's not very helpful after that. Again, antivirals. So antivirals, they work best at as soon as you start to get symptoms, like the cold sores. As soon as you start to get a little tingle, you got to start the meds, and then you won't get the blister. But if you've had the blister for a few days, you can take the meds, but at this point, you need to let the immune system kind of take care of it. So getting it right when it begins, right at that point of replication, right when it's ramping up the replication, that's when these antivirals are awesome. So the guidelines are, you want to give within 48 hours. And then certainly you want to recommend highly for anybody that has risk factors. Anybody that's on chemo, right? I won't try to trick you on this, but in real life, the test question will say within 48 hours or more than 48 hours, right? But in real life, if you have someone who's immunosuppressed and they say they started having symptoms 3 days ago, you're still going to give them Tamiflu. You still should give them Tamiflu. Most recent data shows that Tamiflu can shorten the duration of disease even if you give it up to 5 days after the symptoms start. So just use your clinical judgment, but for the test questions, it'll be within 48 hours, more than 48 hours. That's going to be the thing I need you to remember. All right, so pertussis. This is our whooping cough. This is something that we vaccinate for. You will learn about this again in PEDS. PEDS will talk about this as well. You will see it if you work in areas where it's endemic or areas where we have very vaccination status. In the U.S., obviously, we've got great herd immunity. We don't see it a lot, but every once in a while, we see little pockets of this pop up. So this is usually a child, very, very classically a child, right? They get sick, they're sick for a few weeks, you bring them in, you're like, oh, it's probably a virus, ears look clear, they listen to their lungs, nothing really exciting. And then usually after about week 1 or 2, kid's still sick, maybe they've been seen a couple times. This is when the parents kind of really figured out, they get this very classic whooping sound where they're almost like gasping for air. It's an inspiratory where they're coughing or so much that they kind of have to suck in air very quickly. It's kind of like that croup. Remember after a few days and they get the barking cough and then the parents are like, whoa, this is weird, and they bring them in. Sometimes this pertussis, they're going to come in a little bit later because this is what's really going to bother the parents is this weird cough that they get. You could be amazing and pick it up before that, but most of the time we pick it up once the symptoms start, which is about 2 weeks into the disease. You can swab for this. This is definitely reportable. So if you do swab for it and it's positive, you need to get with your public health office to make sure that it's reported. Z-Pak, not Z-Pak, but azithromycin. That is one of those, and this is one of those, since we don't have this disease a lot, so there's not a lot of resistance, so this is still used very commonly. So this is one of those where, as far as, the people are ready in the pants, this is fair game for a test question on treatment because it hasn't really changed. It's been like this forever. Again, if we started seeing tons of cases of this, we would obviously have to start coming up with alternate treatment plans, but right now, azithromycin is still the way to go. Don't worry about knowing the other one. And then the last thing, we didn't really, I think we were really tired that day, but this is a key point as well that we need to keep in mind, is that once you diagnose this, you need to treat the contacts as well. It's the same treatment. But if they live in the same home, then you need to, or they provide, 24-hour care. If they're close contacts, and that's usually how we describe it, is either living in the same home or spending a certain time out of the day. But if they live in the same home, you will have to also treat the contacts. All right, TD. And this is one of our granulomatous diseases. This forms granulomas. It has a very unique latent phase. So diseases that have a unique latent phase, that's why we have screening for it, because people can have it and not have symptoms. Most people, unless they're screened for it, there's a lot of people that go through their entire lives with latent TB and it never becomes active and they never know about it. Most people miss that primary disease when they first catch it, when the bacilli first enter the body and the lungs start grabbing it up and forming these granulomas or nodules. Most people miss that. Unless you've got a high clinical index of suspicion or you're in an area where there's a lot of TB, a lot of people will miss that. Or you're in an area where you don't have access to health care, right? In a population that doesn't go to the doctor every year or every month that has access. So this latent phase, usually once those granulomas do their job, they contain it, everything calms down. So no active disease, and most people can't transmit it. But if you're high risk, then we want to screen you for it. And we screen using chest x-rays and the PPD, which we talked about was the subcutaneous, where we give them a little bit of the tuberculin, and then we come back 3 days later. We don't look at it for erythema. We rub our finger over it and feel where that skin has become indurated. That's the immune response to that tuberculin. And I wrote no 5 millimeter. So understand when I said which one would 5 millimeters, more than 5 millimeters apply to, know that one. And that was most of our HIV positive, immunosuppressed. So just know that top category when anything above 5, because if you're otherwise normal, you can go up to 15 millimeters. So I want you to know which patient category. Those are those really high risk. They live with someone with TB. They're immunosuppressed. They're on chemo. They're HIV positive. So if their measurement's an 8, then you need to treat them for. You need to consider that active or positive. I'm sorry. That's a positive TST, which means they get preferred. All right, induration, reactivation disease. So that's that. All those movies where people were like coughing blood into tissues, and back in the day, all the Tombstone and all that, blood coming out of their mouth, and they're constantly like lungers, right? Just coughing. So that's when those bacilli get out of the granulomas, and now they're causing disease. They don't just cause problems in the lungs; they cause problems throughout the body. That's why these patients, in addition to the chronic cough, which is the primary phenotype of TB, they also become chronically ill and malnourished. So they're going to have constitutional symptoms were developed for tuberculosis, right? Fevers, chills, night sweats, weight loss, anorexia. So constitutional symptoms, we ask them night sweats, like, do we think she's in menopause? That's one of them, right? But this is what we're talking about. We're talking about someone who has a systemic illness, and that translates into fevers, that translates into night sweats. They're very sick, they're very malnourished while this disease is active. Chest x-ray. Chest x-ray when it's latent, you can see the granulomas or nodules. Chest x-ray when it's active, you can still see some nodules and granulomas, but you will also see this kind of classic apical infiltrate, because once those bacilli are released, they love to go up into those nice aerated spaces in the lungs. So again, classic test question. So active TB, this is that ripe. And I'll give you, I think on the test I actually have like little, what do you call that, like a key? So I'll have it laid out, you know, R for this, I for this, P for this, E for this. And it's a long course of treatment. The latent TB, that's going to be 6 to 9 months of INH with the B6. There are alternate treatments. This is the one I want you to know. Know that one. The alternate treatment is a shorter course of INH with one of the other drugs. This is the one I want you to know. It's still being used. According to our reference, it's still the treatment of choice initially. Again, baseline labs, you don't have to memorize those. But the big ones, the LFTs. Big thing about this is you want to make sure that they're compliant. This is a huge, I think we talked about that in this lecture, that like 1 in 9 people at one point. So it is a huge disease burden. It's a huge public health problem. And if we identify it and we're wasting our time at all to even treat the latent disease, treat it all the way. Because we're already seeing a lot of resistance, hence we have to use 4 different drugs to treat it when it becomes active. So compliance is very important. And this was that little, I said no, to know this population, and if you see them and they're greater than 5 millimeters, then they need treated for, and that's positive PPD. That means latent TB. That's the only one there. So the mitotics. So we've got the histo. Keys to this one to pull it out. Obviously the bats, abandoned buildings, Ohio, Mississippi. Our coxy are going to be, you know, southwest border, digging up dirt, new construction. That'll be the clue. I want you to think coxy. Glasgow is going to be the other one. I don't really test much on that. It's just to kind of complete the list. It's on here. It's just another mycotic infection. There's nothing crazy distinguishing. So those are going to be your clues, right? And then symptoms are all commonly mistaken for mild flu-like. Chest x-ray could have some focal infiltrates. Mediastinal and hilar lymphadenopathy is common to see with these. That's how the body responds to a fungal infection in the lungs. These are often found incidentally. You can test for the coxy and histo in the urine. You can obviously biopsy for all these. And then understanding that, or itraconazole. See, I'm going to update this. So if I describe one of these patients, then it's going to be azole, itraconazole or fluconazole. So I don't know if you guys modify these, but put /itraconazole, because you can use either. So itraconazole, coxy goes with Southwest Valley, histo goes with H. capsulatum, which you could either find in the urine or on a biopsy. Aspergillosis, this is, so that one's this patient with, this is why I always talked about my asthma patients, right? My asthma patients that every time they'd go see the allergist, one of the first things she would do allergy testing, she would check an IgE, and she would check the eosinophil level. And again, was one of those things, if they got to her, that means someone was having trouble treating the respiratory symptoms. So at that point, it was just standard protocol for her to assess for this. Because a lot of times you got these fleeting pulmonary infiltrates, they're not reliable, right? So she would check for the eosinophil level, she'd check the IgE level, and really just looking for a cause, a secondary cause, for why this person's asthma was refractory. Why a primary care person couldn't manage them, or didn't feel like it, so they referred. These are exciting. Won't ask me anything about them, they're just other forms. HIV pneumonia, a lot of different words for it. P. Jerevecki, pneumocystis, pneumocystis pneumonia, PCP, HIV pneumonia, doesn't matter what we call it, associated with patients with a CD4 count less than 200. This is not the only illness. I know you guys wondered about HIV. This is not the only opportunistic infection. This is just the classic associated pneumonia with HIV. This is the one that they'll get. CD4 counts below 200. It'll look like an atypical. And this is another one, just like the pertussis. This is the tried and true med. We've given it forever. It hasn't changed that much. I'm sure it will at some point, and we'll stop asking it as a high yield, but this is going to be that should be your answer for treatment. And then you'll have some specialists be like a door and try to pin you on something. So that's what we need you to know. Obviously, find out if you're allergic to it, but all right, pleuritis. So now we're kind of out of the lungs. We're getting into the pleura. Pleuritis is inflammation of the pleura. It's most closely associated with having a cold or a virus. It's inspiratory chest pain. That means right up here when they're fully inhaled, right? That lung approximates to that inflamed pleura in the chest wall, and it hurts. And that's when they have pain. That's the timing. Sometimes you can hear on that end inspiration, you can hear that pleura, like a balloon rubbing up against that. And really you just treat it. So this is another medication. You put a little, when you make your little memorized chart, right? If I describe a patient like this, and I ask you about treatment, indomethacin. Or any NSAID. I like indomethacin. Pleural effusions. So these are accumulations of fluid in the pleural space. We talked about the pathophysiology. We talked about the hydrostatic pressures, the osmotic pressures. We talked about what inflammation does to the capillaries. That's all great. I hope you remember it. What I really need you to remember is if there's less than 100 mils, you need to do a CT. Now, is that clinically important if it's less than 100? I don't know, but chest x-rays can miss these if they're small. A standard chest x-ray can miss a pleural effusion if it's less than 100 cc's per mils. So these thoracentesis, this is the procedure where you can tap into that pleural space. Usually it's done posteriorly. You can do it as diagnostic, or you can do it as therapeutic, or obviously you can do it as both. Diagnostic is usually when you first discover it. Certainly if you have a unilateral effusion in a patient that has no other reason that they would have a unilateral effusion, you certainly want to tap that. Those have to be tapped because those are more commonly associated with inflammatory or malignant processes. But if it's just a patient who has known CHF and it's 2 days after Easter and they ate like half of the honey baked ham, and then they're, you go in and they have bilateral pleural effusions and they're swollen up to here, you don't necessarily need to tap that, you need to give them Lasix so that they can diurese all that. But unilateral, you want to do a diagnostic tap as well. Diagnosis, so the bilaterals, When it's bilateral, it suggests more of a non-local process, if that makes sense. So it's like when I have somebody with knee pain and it's just in one knee, I'm thinking more something wrong with the knee versus both their legs hurt. I might think it's something above the pelvis, right? So just kind of using your clinical clues. Something else is going on. In this case, most of the time, it's cardiogenic. So the fluid is backing up in the cardiopulmonary system, and then that hydrostatic pressure is causing a transudate, all that fluid to ooze back out of the vasculature into that pleural space. Remember, you lose the costophrenic angles. They will be blunted. You will not see them, as opposed to when we get to respiratory distress syndrome. All right, unilateral, again, we talked about that. Should be, remember, like with my late-stage liver cancer guy who I would tap every few weeks, there would be so much fluid coming out of him, and the stats would start to go up, and he would feel better, and his pain would go, and you'd have to like stop drawing it out because of this risk of causing an edema by expanding those lungs so quickly. All right, Light's criteria, yes. It's another one. So remember your little formula. It's not that hard. But it's kind of like not intuitive. But just remember, you're looking at your protein and your LDH, and you're comparing your serum to your pleural. That's really all you need to know. 0.5, 50% for the protein, and 60% for the LDH. So write those down in your little white paper right when you get it, so that you're calm when you're seeing a bunch of numbers. And really all you have to figure out is if the ratio is greater than 50%, or if the ratio is greater than 60%. That means if the fluid in the area has 50% or greater compared to the serum, then that fluid is considered to be high protein, and that's an exudate. And same thing with the LDH. If the amount of LDH in that pleural fluid is high enough, then that is considered to be associated with an exudate, a more local problem with the lung, because LDH goes with inflammation. So you'll forget it, you'll have to look it up again when you're in phase 2, but remember it real quick for me for a test. Alright, and just some special examples. Empyemas, so if the fluid's got white blood cells in it with evidence of bacteria, you give antibiotics and you drain it. If it's blood, which I won't ask you about hemothoraxes, but if it's just blood, drain it out. It's intuitive, you don't need antibiotics. Now there's also something called pneumonic effusion, where if you find that, you test it, and if it's not full of bacteria, you don't necessarily need to drain it. My confusion always is, if I tested it, why shouldn't I just drain it anyway? But anyway, you don't necessarily need to drain it if there's no bacteria in it. But certainly if you have bacteria, then you need to drain and give antibiotics. Pneumos, again, we showed you that little picture of those apical blebs. Tall, thin people are at higher risk for developing those because of the tension on the chest wall. So we've got two types of pneumothoraxis. What do you think? Pneumothoraces? Yeah. So primary, we've got this kind of just associated with familial body habitus, obviously worse with smokers. All right, it's nothing caused it, right? But it's just based off of them, who they are as a human being. It's just they're at higher risk based off how they were born, a little bit of what they do to themselves. Then you've got secondary. This is just a pre-existing condition that makes them more at risk for developing it. And this is a patient that is going to be out, 20-year-old male out, smokes, came in, you know, late because he had a cigarette on his way in, was running a pizza test, felt sharp pain, unilateral, developed shortness of breath, had pain. They're going to come in, they're usually going to be a little tachycardic, but not always. Maybe a little tachypnic, but not always. Maybe a little hypoxic, but not always. If they're stable, if it's small, they might not have any symptoms. It might be a history of something, if it's very, very small. So if only one of those little bloods rupture, a little air gets in there, it will resorb on its own. It'll heal and resorb on its own. If it's bigger, then they're going to obviously be more symptomatic. So you bring them in, you determine whether they're stable or unstable. Mental status is normal. Vital signs are normal. General appearance, they're not having retractions, they're not tripoding. You get a chest x-ray. If you think it, get a chest x-ray. If it pops in your head in the differential, get a chest x-ray. Don't have it pop in your head. This is not something that you necessarily would rule out clinically. If enough symptoms add up, get the chest x-ray. Just get it. And then you get to get your little calipers out. Because if you see it, which is again that loss of typical lung markings, which if they're very small can be very subtle. So have a radiologist look at it with you. If you think you see it, it's like hearing a murmur, right? I think I hear a murmur, and like, it's not a murmur. But you thought you heard it. But get good at that because you might have to read one in the field. If they're small and the patient's stable, you can just observe it. If that's in the field, I wouldn't observe out in the field. I would just get them out there. Don't, unless you have to. Like if it's like, right, there's times where I have done things that I would not do in this type of setting because they really didn't have an option, or because they said he's not waiting anything necessary. So that happens sometimes. But you want to just observe it. Repeat that chest x-ray in 24 hours. If it hasn't progressed, then they can go home. If it's large, then you need to make other considerations, right? Are they unstable? Certainly you need to, first step will be needle decompress. So if I give you a patient who had trauma, who has a puncture in their chest, who's severely tachypnic, who's severely hypoxic, who's tachypnic, tachycardic, altered mental status, tracheal deviation, right? All those things that are saying that that person is sucking air into that side of the chest that got traumatized, and now that lung won't inflate, so they're just operating off of one lung. And now they're sucking in so much air into that one-way valve that they're actually deviating their trachea and deviating all of their vasculature, including their heart, into that other lung space, and that could end up causing significant hypotension. That is get a needle decompression in there and figure out how to get a chest tube in this person. And we've all seen the patients that come into level 2s or level 3s where they've got like 6 or 7, right? They got the chest seals that are kind of like on sort of, and then they've got like, you know, multiple, and so that's just someone watching the patient go to respiratory distress again and popping that air out of the chest until they can get a definitive seal and get a chest tube in that patient. So try to get them in as soon as possible. And that's it. What slide are we on? 14. Interstitial lung disease. Interstitium, remember it's a misnomer, it kind of affects all of that respiratory zone. So if we think back to that drawing we had, we've got the parenchyma, and in between we've got these fibers. That's the structure. That's what interstitium means. It's between the functional cells of the organ. And so a lot of the issues that come out of this interstitial lung disease is fibrosis issues, fibrotic issues. So something causes inflammation, and then you develop fibrosis as a result of that. It's like a keloid on your skin, but it happens within the lung. And what that does is it replaces normal functioning lung tissue with scar tissue. So very, very important part of our lungs. And the problem is that when this happens throughout the lung, because of a systemic problem, then you start to lose lung function kind of everywhere all at once. This isn't like a PE where one part of your lung isn't functional. This is affecting every single part of your lung. And it ends in death, right? That's pretty traumatic, sorry. I showed you, remember that huge list of all the different reasons? When you refer these patients, because that's what you're going to do, you're going to refer these patients if you identify it. When you refer these patients, the goal is to see if we can figure out if there's an underlying cause for it. If it's something they do at work, if it's something they are exposed to at home, if it's something that they're taking, if it's another medical problem. But unfortunately, in most cases, we don't know, so we call it idiopathic. We don't know why the patient's having it. There's no correlation to their job. There's no correlation to anything that we can say, stop doing that, stop exposing yourself to that, stop taking that medication. But we try to. That's the goal of identifying this, is that there might be something we can do to stop progression to death. All right, so these patients are classically going to present. It's going to be a primarily short of breath, not necessarily a cough, so not an airway problem, so to speak, where they're coughing a lot. It's not postnasal drainage. It's not nighttime coughing from asthma. It's not our COPDers. So when it's down in the lungs, primarily in the parenchyma, it's going to be more shortness of breath. They're going to be short of breath. And I'm getting real short of breath. And the problem is, a lot of these people just think it's part of aging, especially if they smoke. And they think, well, I smoke and I'm getting old and I should be short of breath. But when you see them, it's not going to be like 92, especially if you get these patients up and you walk them, their stats are going to drop significantly. Because they've only got whatever's left of their lung, they've got only like limited surface area to exchange that oxygen for carbon dioxide. So exertional desat goes with interstitial lung disease. That's that ground glass. So instead of these nice little areas of fluid, which will look more like little infiltrates, right? Wispy infiltrates. This is more tissues and fibers, and so it looks a little bit more sharp on the edges, almost like your ground glass. It's got a little bit more of an edge to it. And then this honeycombing, I don't know if you remember back to that picture, but as that fibrosis replaces all of that tissue, it kind of carves out a space. And this honeycombing, you actually see that fibrotic tissue, and it's in the middle, it's where all of that alveolar tissue used to be. It's another radiology term. I hope major passion went over. This is put a little yellow on this one. This is one of my trick questions. Remember, when I'm asking you about PFTs, look at the whole history. Make sure you read the whole question and go back. Because although interstitial lung disease, typically, right, it's in the lungs, it's down in the actual tissue, the parenchyma, so that would make sense that our tubing's fine, right? Our FEV, FE1, FVC ratio is fine. It's just that we don't have as much vital capacity because we've replaced lung tissue with scarring. Just make sure that you're looking to see if the patient would have any other reason for having obstructive airway. Make sure you look at the entire patient. All right. The definitive diagnosis requires bronchoscopy. Most patients, you cannot make the diagnosis off of just the imaging. It's highly, highly, highly suggestive, but in most cases, they're going to want it to be, mostly because that might give us a clue what's going on as well. We might find something pretty cool. And then you refer. Know this one too. It's an inflammatory process. There's a lot of scarring. The best thing you can do for those types of situations is give them steroids. So in most cases, not to say that you should in most circumstances be managing these patients, but understanding that in general, and this is one of those treatments that goes along with one of those topics on the pants that we expect you to know, it's going to be steroids. Steroids, ground glass, exertional desaturation, those are your buzzwords. All right, sarcoid, This is another granulomatous disease, although as opposed to TB and some of our fungal infections, you will not see that central necrosis because that's not what was in there. It's actually the granuloma formation is what the disease is. So patients will form these granulomas kind of like, almost like an autoimmune. Really, it is an autoimmune. So something in their immune system is not doing what it's supposed to do. It's producing these granulomas. It happens throughout the body. A lot of patients come in with primarily respiratory symptoms. Just like the mycotic pneumonias, sometimes they can be a little vague. People don't really pick up on them. We don't think sarcoidosis right away unless it's in our differential. Gotta make sure stuff's in our differential. Yep, so it can be kind of vague. You gotta be thinking of it. Not everything is depression, right? A lot of it is depression, but not everything is depression. Right? We need to make sure that we're thinking clinically and objectively, because all the way at the bottom, you know, psychosomatic, followed by lingering, right? You got to make sure as clinicians that we're making sure we've ruled out every other possible medical cause for that before we tell them to start an SSRI. Couple of unique things, again, it's just like that red currant jelly stuff. These are just buzzwords that if you remember mycotic suture right, then maybe it'll help you get a test question right on the pants. But this erythema nodosum, again, not unique to sarcoidosis. We see that in a lot of other diseases, but this could be a clue that we're talking about sarcoidosis. The lupus corneo, that is a little bit more unique. Those are those dark lesions on the face. Polyarthralgia, that's a migratory polyarthralgia. Let's see here. It's another one we make a biopsy. Then we've got the granulomas without the central necrosis. That's the definitive diagnosis. Okay. Hold on, let me think here. The subtypes. Yeah, put those in your brain too, please. I can't remember, but in your brain. Make some little mnemonic, I don't remember them. Lofgrens. This is going to be where they've got that erythema nodosum plus the migratory part, polyarthralgia, plus you get a chest X-ray and you see bilateral lymphadenopathy. The reason it's important, the reason why we care about both of these, is that it's a, you can make it a 90, that's which is huge. So it's got a 90 plus diagnostic. Hair forts, that was that picture of that patient. She's got uveitis, keratitis, and then she'll have a fever. And treatment is really referral. That's all I wanted you to know about that. You refer them. Good news is most spontaneously resolve after about 1 to 2 years. I bet you there's a lot of patients that probably go with undiagnosed. I don't know what was going on. I just felt like crap for a couple of days. Occupational asthma. So the timing on these, pay attention to the timing. The timing on these is important. If I tell you symptoms come on at work and then go away when they leave work, that's more of an acute hypersensitivity response. That's more the occupational asthma, which we all know is a airway problem, not a parenchymal problem or an interstitial problem. So that's going to give us our FEV1 FVC ratio decrease. And like with all these occupational ones, number one treatment is going to be figure out what it is and avoid it. So the timing on this one happens down in the alveoli. This is more of an immune response. This is more of an allergy response, quick on, quick off. This is more histamine related. This one's more immune related. So you get exposed, and then your body starts to make, the immune system kicks up and everything. So it's not within hours. It's later on during the day. I go to work all day, and then while I'm at home in the evening, I always feel like crap. I was off for a week last week, and it kind of got better. And then when I started going back to work, it got worse. So timing of symptoms. It's one of your OPQRST. Don't forget, it can be very, very critical in giving you clues to what's going on with someone. It's down in the, so again, fevers, chills, malaise. This isn't chest tightness, this isn't wheezing, this is an immune response, like when you get a flu shot. Those are the symptoms they're going to say. It's down in the alveoli, so it's going to be restrictive. And then the key is figure out what it is and avoid it. Stop your maple tree bark company or whatever those funny goofy things were. All your organic, whatever the organic thing you're exposing yourself to. Toxic lung injury. Another word for that's bronchiolitis obliterans. So right away when we see bronchiolitis, right, we're going to think obstructive. So bronchi and bronchioles. So PFTs for that one is going to be an obstructive pattern. These are our fumes, our toxins, our chemicals. So-and-so worked in an ammonia plant. So-and-so worked with this. I haven't started using patient vapes with this one yet because we don't have the medical data yet to link this, but I guarantee someone in the next 10 years is going to be using a vape patient. The longer we vape for, I could probably predict when we'll start seeing incidents of toxic lung injury increasing in our population. Because again, we're talking about chemical fumes that get down to the bronchioles and cause inflammation. Not reversible with a bronchodilator because it's not a hypersensitivity. You're actually causing inflammation from the fumes and the chemicals you're exposed to the bronchioles. Consult. There's nothing really else. Just correlate toxic lung injury with inflammation of the bronchioles, obstructive pattern, toxic fumes, vapors, ammonia, and referral. All right, smoke inhalation. These were our three things we need to consider when we're evaluating someone who got pulled out of a building or pipe blew up in their face. This is very pertinent to every service because we all are around things that blow up, right? Machinery, buildings, ships, planes, whatever. And so assessing someone who, the first thing you could think of is making sure you train all your medics that if they're moving patients like this, then they need to make sure that they put oxygen on them, right? So that's one of the most important things. Because the leading cause of death is usually hypoxia, and so you want to get oxygen on them right away, and a non-rebreather. So we talked about thermal injury to the upper airway. That mucosa is very, very sensitive. It can swell up really, really, really big, right? It's not like a lower leg where we develop compartment syndrome, right? The tissue can swell like crazy. If you've ever seen it with angioedema, that mucosa can just be engulfed in fluid. Problem is, it will close off your airway. So this is one that happens earlier than later. This is that first 24 to 48 hours of monitoring. Well, they were brought to the hospital. Well, they were fine. Why weren't they released? Well, we watch them for about 12 to 24 hours. We want to make sure that this stuff isn't going to develop. So watch for that. Have the patient keep talking. Don't walk in there and look at them and leave them in the room. You have patients coming in that have history of smoke inhalation. Pull all your kits out. Make sure you have your tubes. Make sure you have your blades. Be thinking of all these things. All right. So then we have things that cause problems with oxygen. So this causes problems with air getting in and out, right? This is problems a little bit lower, where now we're having problems with oxygenation. One of them is carbon monoxide, so a lot of stuff that burns. You get exposed to carbon monoxide, it displaces on the hemoglobin, displaces the oxygen. Really, really, really sneaky, because you can put a pulse ox on these people and it can be 100%. That's why everybody just put oxygen on them. Put it on a non-rebreather mask, not a nasal cannula, a non-rebreather. Regardless of what your pulse ox is. And you do all your intake, and you ask them if they have headaches, and you ask them if they have all the symptoms. Then high flow, O2, non-rebreather mask. Then the cyanide, this works at the cellular level. It causes lactic acidosis because the cell cannot produce ATP. This is, this is the classic, cyanide poisoning. Poisoning people with cyanide. It's very, very rapid. It shuts the organs down very, very quickly because the cells literally cannot make ATP. And so you die very quickly when you're exposed to high levels of this. This comes out of some materials that we produce with that are in a lot of these buildings. Is it cyanide poisoning? Right now, it has cyanide poisoning. Right. Yeah, O2 is not going to help. Won't correct hypoxia because, again, it's not an oxygen problem, it's a cellular problem. What you need to do is you need to, remember our good old vitamins? Vitamin B6, vitamin B12, they're nature's cures for a lot of these naturally occurring things. So something just to keep in mind, especially if you're going to be working in areas where that is a risk, where people could be exposed to smoke inhalation. You need to consider that, having those kits. And then the last one, this is the lower airway, this is the bronchioles. It's very similar to kind of like a toxic lung injury picture, where the bronchioles become inflamed, you have an obstructive airway disease. So just the third area where the lungs can be affected. This will take a little bit longer. So most patients, I would say at least 72 hours in the hospital after something like this to make sure that they continue to improve. They also love to give pneumonia as well. So. All right, we're at an hour. This slide line. Do you guys want to try? No. Dang it! They're pretty much up there, right? The words are up there. Most of the ones I think are, I've done this for multiple semesters, so highlighted, underlined, colored, those are the words I care about. For this pneumoconiosis, it does occur down, these are tiny little dust and fibers, so they get all the way down into the parenchyma of the lungs, down to the alveoli. So we're going to have restrictive patterns on all these. And interstitial lung disease, that's restrictive. Pneumoconiosis are restrictive. Allergic bronchopulmonary aspergillosis is obstructive, right? That's the bronchioles. So put those together in case I ask a PFT question. Co-workers, that's our black lung disease. Anthracosis is another word for it. Get the coal dust all the way down into the lungs. It's dust. It makes it all the way down to the parenchyma. It starts staining it. Creates these cold macules. They start in the upper lung fields, and then eventually they make their way down into the rest of the chest. This was obviously a much bigger problem back before we had OSHA, back before we had occupational health, where we were screening for these, where we were wearing protective gear. It is that's really the only way that we can address this disease, because once they get into later stages, there is very little we can do. The goal is to prevent the cold macules, from forming by eliminating exposure to the dust. Second one is silicosis. That's our quartz mines, our silica mines. Again, we referenced the movie Apocalypto. If you haven't seen it, it's amazing. You should watch it. Covered in kind of that white silica powder. It's down into the parenchyma as well. Causes calcification of the hylar nodes. So these are very unique. That's a easy word association for if someone's talking about silicosis, are these eggshell calcifications. Very unique how that silica creates that image on a chest x-ray. The other thing I need you to correlate with that silicosis is the patients who have silicosis. So an old guy who was a stone cutter, who's got all this stuff. He's got restricted pattern. He's got calcifications. He's got eggshell calcifications. And then the question is, what do we need to make sure that we're doing? And that is screening for TB. The changes that the silica causes in the lungs makes people at much higher risk to sets up the playing field for TB. So we have to screen them lifelong. Asbestosis, these are our insulators, shipyards, pipe fitters, anything where they used to put this asbestos, it's a fire retardant, and we used to use it as a fire retardant in a lot of these construction areas. About 1989, we banned it. This is about when we started to see a bunch of patients coming in with progressive restrictive lung disease. Chest x-rays show pleural changes, so very unique to asbestosis is that it causes changes in the pleura. That's a great clue. You feel lost on the question and you see something about the pleura, it's, you know, of course there's pleuritis, of course there's pneumothorax, but if we're talking about respiratory symptoms otherwise, then tie that back to asbestosis. So we can see some honeycombing, pleural plaques, and then the last one we'll touch again in our neoplasm lecture, our cancer lecture, is this association to a rare pleural cancer. About 80% of all cases of this rare pleural cancer are associated with asbestosis. All right, so here's our PE. Patients that I want you to suspect PE in will have one of the Virchow's triad. So they'll either be post-op in the hospital, they'll be immobilized, they'll have some sort of hypocoagulability, dyspnea, inspiratory chest pain, and tachypnea. They'll be short of breath, they'll have pain in their chest, and they'll have a high respiratory rate, usually over 30. Chest x-ray won't be that helpful. Your job will be to, number one, decide how to evaluate it. But even before that, you're going to have to decide whether or not they're high risk or low risk by using this Wells score. So understanding that these are going to be our clues. Once we hit 4, then we go straight to imaging. So a patient that's very low risk, that has no history of VTE, doesn't have a history of cancer, that's not having hemoptysis, someone that's got a very, very low Wells score, we start with a D-dimer. D-dimer is great to rule it out. So if it's negative, pretty sure they don't have a PE. So that's a good one. Or at least one caused by a DVT, right? But if they do have a high pre-test risk, then we're going to go straight to the imaging. This is another one. This is another one, right? CTPA versus VQ scan. I give you the reasons that you should consider VQ scan first. Look in the whole question, right? Because they might have something that tells you they don't have one thing, and you're like, oh, they don't have this, good, I'm gonna order, but keep reading, make sure you read the whole question, that's the other one. I wanna make sure that you're looking at catching all of those indications. So maybe a patient where I say, otherwise healthy, no renal disease, but then I make you pregnant, right? So just keep your eye on that. Make sure you look at the whole question. This is what patients will love to do to you. You have to make sure that you know all of the criteria. So that's that. I want to ask you about anything about treatment. Because you will, PEs are first managed typically in the hospital. The pulmonary hypertension. Lots of different reasons. I don't expect you to know the different categories. There's a lot of, that's how they categorize it by the cause, what's caused it. It is 25 millimeters of mercury, greater than or equal to. You need to cath the heart to get that. This is not something you can check peripherally like a blood pressure. And then, big thing I want you to remember is that cor pulmonale is the term we use to describe the physical changes to the right side of the heart. So the term means pulmonary heart. So it's those changes from that pressure being very, very, very high in that pulmonary artery, which is full of deoxygenated blood. The same thing that happens to the heart, left side of the heart in hypertension, where that heart's squeezing that blood out and it's all, the changes happen to the heart where you get that left ventricular hypertrophy. This is the description of those changes on the right side of the heart. And that term is called cor pulmonale. Wegeners and Goodpastors. These are vasculitis, vascular disorders. They affect the pulmonary vasculature, not singularly. You won't hear about these diseases again when you're with Colonel Evans in GU nephrology next semester. The Wegeners, the Goodpastors, right? They have different. They're both associated with kidney, with glomerulonephritis as well. We teach them here as pulmonary vasculitis. And the symptoms they cause. With this Wegener's, the pulmonary aren't the predominant. Usually they're identified in the kidney. So this is more of a renal presentation, but these other things that can be associated with it, again, you'll learn about these again in nephrology. With this saddle nose deformity, we'll need to go back and look at what those look like, especially that one. That'll tie you back to Wegener's. Another clue would be referencing these ANCA antibodies. I don't expect you to, if I asked you like, what's the antibody? That's like a first order question for me, I wouldn't do that. But if you see that in a question, then that'll give you a clue that I'm talking about Wegener's. Don't really talk about treatment because you won't treat it. Goodpastors. Very similar. It's an inflammation, a vasculitis in the pulmonary vasculature. This is a little bit more presented as pulmonary symptoms, but not by that much more, but patients can have more respiratory symptoms with this. And then this is the anti-glomerular basement membrane. So if you see that, that should tie you back to the questions. Not going to talk about treatment because you're not going to treat it. This is on the PANCE list. I need you to understand what it is, how you diagnose it, how it presents. Treatment is not going to be one of the things that the PANRE is going to expect you to do. All right, respiratory failure. All right, so either not enough oxygenation or not enough ventilation. It's either because you don't have enough oxygen in the blood or because you have too much carbon dioxide in the blood. And then we talked about how that carbon dioxide leads back to hypoxemia as well. So they present similarly, regardless of whether this is a hypoxemic or hypercapnic respiratory failure, they present very similarly. Remember, you're at higher risk for hypercapnic respiratory failure. And you have any of these are the diseases that make you at higher risk. I'm going to circle the COPD. That's the one we most commonly come into contact with in primary care. So these are the patients that we're worried about. These are also the patients when we talk about replacing O2, right? We have a lower goal for them. We don't want to try to give them too much oxygen because their bodies aren't used to it. Treating respiratory failure, you got to figure out what's going on. You got to figure out why they're in respiratory failure, and you have to correct it. If it's because they're septic, then you need to start them on antibiotics. You may have to intubate them to support them while that medication is correcting the underlying cause. Versus someone's in respiratory failure because they have a foreign body aspiration, you pop that thing out, and then you immediately have corrected the underlying cause. So sometimes the underlying causes are easy to fix. Well, not easy, but sometimes you can fix them very quickly. And sometimes it's a pathological process that's going to take you days to treat. And most of the time, we're going to have to support respiration in the meantime. So, we'll talk about ARDS next. This is why we have an ICU. This is why we evacuate patients that are at risk for acute respiratory distress syndrome. This is why respiratory failure is a big deal. This is why it makes everybody get nervous. This is why I have an airway kit hanging on the wall, and I make sure people know how to use it. It can happen very quickly, and there's a high mortality rate associated with it. Airways are scary. We need to get good at identifying underlying causes, correcting them if we can, and then certainly intubating people if we need to, how to apply oxygen, and getting them to higher levels of care. ARDS, this is where your lungs turn into sponges. Within a week of ARDS setting in, something happened, right? There's within 1 week of clinical insult. That is part of the diagnostic criteria. So that has to exist in order for this diagnosis to be of concern. Then you have the bilateral opacities. We saw pictures of that. Maybe remember like day 1, day 2, day 3, and you can just see costophrenic angles are there though. It's not a pleural effusion. It's not filling up that cavity. It's actually the fluid is getting absorbed and sucked into that actual parenchyma of the lungs itself. And then it cannot be associated with a fluid overload problem like CHF. So you'll see these rapidly confluent bilateral infiltrates, spares or costophrenic angles. You may see some atelectasis or collapsing of the alveoli in certain areas, because remember what happened to that surfactant, right? So the alveoli are not staying patent, fluid's filling up. These bronchograms, air bronchograms, which is not any changes to the bronchi, they just stand out against on the x-ray better because all that fluid's behind them. It's like creating contrast in a picture. But then we have a term for that. So when we say air bronchograms, that suggests the patient's in acute respiratory distress syndrome. And most of them will show that. Again, treat the cause, intubation typically required. This is similar to respiratory failure. We want to try to correct the atelectasis with some PEEP to blow them open, but you don't want to get crazy. You don't want to cause barotrauma. And then the tidal volume, right, the volume of air. You start with about 500 cc's, and then you check your ABGs to see. There is a sweet spot. It may not be the 500 cc's. You may have to lower that tidal volume for a while because all the lung space is taken up by fluid. So you have to be judicious. You have to get those ABGs, and respiratory techs are amazing people. If you're in the ICU, spend some time with them, watch what they do, They're really amazing chemists when it comes to adjusting all that, so that while the patient's recovering, or while they're in that state that they're in, while they're septic, while they're recovering from whatever, we can maximize delivery of oxygen to their tissues. Let's see, anything else on here? This is neonatal. Not enough surfactant. Before 28 weeks. 90% of neonates before 28 weeks have it. So, the neonates, what happens when somebody goes into premature labor? We try to stop it. We put them on tocolysis, right? Bed rest. We used to treat it with giving literally patients alcohol, IV alcohol. We used to have all these moms like all drunk on the before we had Tributylene. We used to literally give them alcohol. I would have been like, oh, I'm in premature labor. Again. So this is what happens. The alveoli cannot reopen. There's not enough surfactant. So again, you'll learn about the APGAR. We'll talk about this with Major Klein next semester. The big thing is, I'd like you to understand that if you have a patient that is delivered before 28 weeks, and they're tachypnic, and they're cyanotic, and they're premature, then you give them surfactant. That's it. That's all I need you guys to know. And I'm not gonna belabor this. So obviously, this is a prenatal thing that you will absolutely learn about with Dr. Love next semester. So we'll just stick to. We're layering education right now. You'll get it in peds again, and then you'll get it in SIR. Well, all right, when to supplement. Understand, someone with COPD has a goal of greater than 88% versus someone who doesn't have COPD, their goal is greater than 90%. I'll leave it as simple as that. This one, the as simple as that. Well, that's a lot of stuff on that slide. Sorry. I try to get down to like just 30 slides, but all right, so the concept from this that I'd like you to know, these are all very important, right? But the concept that I'd like you to memorize, alkalosis and acidosis, understanding that if you overventilate someone, meaning that their tidal volume's too high or the rate's too high, you overventilate them, you blow off too much CO2, right? Acidic CO2 is leaving your body and you become alkalotic. So if you overventilate someone, if the respiratory rate's too high or the tidal volume's too high, get your ABGs, you will see a respiratory alkalosis. That means you gotta either turn down your respiratory rate, turn down your tidal volume, or both. And then you have to recheck your ABG. There's a lot of other things I can tell you, but unfortunately the patient's not awake. You're setting their respiratory rate, and so ABG, you get a lot of ABGs in the ICU, especially on intubated patients. Acidosis, that's the vice versa. That means when you're breathing too fast, or the tidal volume's too low. No, too high, sorry. Sorry guys, I want to say this backwards. Yep. So the respiratory rate's too high, tidal volume's too high, then you're, no, too low, sorry. You're not ventilating enough CO2 out, you become acidotic. So you have to turn down your tidal volume, or excuse me, turn up your tidal volume, turn up your respiratory rate. All right, sorry. So that's the concept. Keep that one in mind. How you affect the oxygenation is with your fraction of expired oxygen or your peak. That's how you affect the oxygenation. Tidal volume and respiratory rate affect your ventilation. Neoplasms. Literally, I think I'm not supposed to go. Like in the desert. Alright. So this I told you already, this is going to be one, know these three. If I give you 5 different patients, look for the one that's between 50 and 80 and has a 20 plus pack year history and is either currently smoking or quit within the last 15 years. It hasn't been more than 15 years. So know that. Please, God. First step, evaluating a solitary nodule in the lung. Especially if it's an incidental solitary nodule in the lung. If you see if there's an old image that you can compare it to, because instead of getting CT scans every 3 months for the next 2 years, you can tell them that day, it's been there for 2 years, it hasn't changed. This is a benign pulmonary nodule. But that's all they have, by the way. That's a good thing. So look first. Please look first. All right, perineoplastic syndromes. And that's a term I expect you to understand. You're going to go over that again with Tanner Bond next semester. That one's not really high yield in terms of words. The Pancoast tumor. This is going to be the tumor that's up in the apex of the lung. As such, it is vested in the brachial plexus, the pleural ribs and vertebra. As such, it frequently presents as shoulder pain. In MRIs of the shoulder, they're in PT for 6 months. The shoulder's not getting better. Oh, by the way, the MRI is completely normal, but they're still getting this pain. Oh, by the way, they're losing weight, they're having night sweats, etc., etc. This also can translate if they have interference with the brachial plexus. They can start having, in addition to that shoulder, they can have hand and arm symptoms, they can have atrophy, and then sometimes because of that location, they can actually impair the venous return of the superior vena cava, and so patients can have unilateral. That's a very weird thing for somebody to come in and be like, my neck and my face and all that swollen on one side. That's not normal. That person needs a chest x-ray or a chest CT. And then this one's fairly unique. This is when the tumor presses on the paravertebral sympathetic system, and then we get this ptosis, meiosis, anhidrosis. Ptosis, the pupil meiosis, and then the non-sweating anhidrosis. And it's unilateral. Here's our nodules. Those three that I circled there. So no, this is important. I'll circle it again. All right. Check to see if we have old images. If you can. And then the next part is understanding what the characteristics of malignant, which is what the characteristics of benign are. This I will not ask you this, you know. Serial CTs at 3, 6, 9, and 12. Serial CTs at 4, 10, you know, I won't do that. It'll be very basic. But understanding, if you do not have any old images to compare it to, then you have to decide whether it's malignant or benign. Small cell is only 50% of our cancers. These are smokers. This is central. Those are your clues. They're going to be smokers in the test questions. It's going to be a central lesion. There's a higher association with the perineoplastic versus the non-small cell. The second one that you potentially will see is the adenocarcinoma. This will be a non-smoking female. This is the most common cancer. It will be a non-smoking female, and the key is the lesion's going to be more commonly in the periphery. It'll say a peripheral lung mass, not a central one. So this will be like the small cell and the squamous cell will be 75-year-old male who's been smoking for 8,000 years, comes in with recent weight loss, increase in cough, blah, 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 blah. Versus, 45-year-old non-smoking female comes in with all those symptoms. And when they chest x-ray her, they see a mass in the periphery, not in the central. And that has to do with the type of cells. The central ones, it makes more sense. Those are epithelial cells. Those are because we're literally introducing that toxin into our body, and then the cancers are forming right at that entry space, versus things that are more genetically modulated, which occur in a very different, bizarre way, and happen, unfortunately, to non-smokers. That is all. I think this is one that, this one, carcinoid equals surgery equals great prognosis. And then mesothelioma equals pleura equals asbestos. And I think you guys are going to do great. The study slides will get you 99. You can't get a 99.